Oh, Tabby, you're muted.
Welcome, everyone. I'm so excited to be here this week with you all from the Academy of Integrative Health and Medicine. Today, we have just such a special group here. Through our Integrative Practice series, they'll be speaking on Centering Relational Health, the Integrative Pain Management Program at People's Community Clinic. So we're really just thrilled to have this whole team here. We're excited about the presentation, and we just take a couple minutes as everyone is coming into the room to welcome you all and to talk a little bit about AIHM. So the Academy of Integrative Health and Medicine is a global interprofessional integrative health association working to transform healthcare, body, mind, spirit, community, and planet. And we are multiple organizations that have merged over the years, and we're really bringing together clinicians who are working in whole health, integrative health, and holistic health to really transform medicine on this planet together. So we're really excited to have you all here. If you aren't on our YouTube channel, feel free to join there. We post everything. All of our live webinars get posted thereafter. So if you aren't able to join us here live today, or you have to leave early or anything like that, you can always go back and check out the webinars there and share it with your friends, colleagues, and patients. One other thing we're really excited about, we have an incredible interprofessional fellowship program for clinicians. Our next available cohort is starting in April of this year, and we have a great early bird special. So if you're interested in applying to this program, we have a special happening right now that's $2,000 off tuition and $100 off the application fee. So this is a significant savings, and this is running through December 31st. So if you're here, mention the webinar and you can get the discount. So today I just want to let you all know that this Integrative Practice Webinars project is really around increasing understanding about integrative practices. And the ACIH partnership really has shepherded in all these amazing presentations. And I'm going to turn it over now to Dr. Mitchell Zeifman, who will be hosting the program for us today. Welcome, Mitchell.
Thanks so much, Tabby. Thank you, everyone, for joining us today. It's a real pleasure to introduce this program and today's participants. I want to say a big thank you to all the other team members on the Integrative Practice Webinars project. We've been doing this for a number of years. Today's webinar is the 14th in our series, and as Tabby was saying, our previous webinars are available on the Academy's YouTube page, so please check those out if you missed them. There were a lot of excellent information in there. A little bit about the Integrative Practice Webinars. The aim of this series is to better understand factors that lead to successful development, practice, and maintenance of integrative practice settings, and to identify major challenges and facilitators in establishing and continuing to provide integrative care. The IPW series brings leaders and innovators in integrative clinical medicine to educate and inform audiences of practitioners, educators, students, and others interested in the field like you. So thank you for joining us today. And I'm really pleased to introduce our webinar topic and our participants for today. The People's Community Clinic, a federally qualified health center in Austin, Texas, has created an integrative pain management program aligned with the best practices to better serve its patients living with complex chronic pain and trauma. The IPMP integrates numerous evidence-based services offered at the clinic, including primary care, behavioral health, substance use treatment, nutrition, acupuncture, yoga therapy, group medical visits, and medical legal services. The goal is to improve patients' quality of life, mitigating opioid prescribing, and address inequities in the healthcare system around pain care. And in the session today, participants will learn about the different components of the program and how centering relational health can transform the patient experience and their healing journey. You can see the team on the slide in front of you, and I'd like to introduce Dr. Sharad Cohill, who will be leading the team through this presentation. Dr. Cohill.
Hi there, let me pull my slides up really quickly here. So let's see if I can do that. And can you all see that? Okay, great. Let me just make sure that's working over here. All right, so hi there, I'm Sherrod Coley. I'm the medical director for the Integrative Pain Management Program. And thank you so much for having us here. We're really excited to be presenting. And so as we mentioned, we're going to be discussing this program here at People's Community Clinic. And so we brought most of our team with us today. And over the course of this hour, you'll get to hear from everyone about their role and their unique perspectives on various aspects of the program. Unfortunately, a couple of people weren't able to make it today, Kelly Roberts and Jen Beltran, but we'll have others who are going to be covering their portions. But I'm going to give you a brief overview of the program first. So People's Community Clinic was originally a free clinic started over 50 years ago by volunteer doctors and nurses in a church basement near the University of Texas campus to take care of students and others who didn't have access to health care. It grew and expanded and began to care for an increasing number of working Central Texas families. In 2012, we became a federally qualified health center. We currently serve close to 20,000 patients, about 85% of whom identify as Hispanic Latinx. And almost 2/3 of our patients prefer another language, mainly Spanish. 40% of our patients are on Medicaid or CHIP, while almost half, including most of our adult patients, are uninsured. And you have to remember that Texas still has not expanded Medicaid. As is common in FQHCs, many of our patients have experienced complex trauma. Often that trauma manifests itself as chronic pain, substance use, or mental health issues. Since we have such a high number of uninsured patients or patients with pain don't have easy access to imaging, specialists like an orthopedist or rheumatologist, or even physical therapy. They definitely don't have access to the growing number of evidence-based non-drug approaches. What that means is that there aren't a lot of options for practitioners to help patients with their pain other than medications. Now, we're lucky that in our clinic, we haven't historically had a lot of patients who've been prescribed opioids for pain. But given their trauma histories, they may end up becoming dependent if that's all that's offered to them. So as a result, we decided to build a program that effectively addressed trauma and pain through evidence-based non-drug treatments as a way to improve patients' functioning and quality of life, but also to prevent people from ending up on opiates. And based on our patients' circumstances, we really didn't have much of a choice but to build it in-house. When we developed this program in 2018, we already had a lot of resources in the clinic, including a robust trauma-responsive integrated behavioral health department, nutritionists and cooking classes, acupuncture through a partnership with our local Chinese medicine school, AIHM, which had been running student acupuncture clinic, and a medical legal partnership, which helps patients address unmet legal needs. So for instance, if they're facing eviction or if they've had a disability application denied, lawyers can be incredibly helpful. Our lawyer wasn't able to make this talk, but we are going to put a link in the chat, which describes our medical legal program if you want more information about that. Now, around that same time, the federal government was providing funding to FQHCs to combat the opioid epidemic. We utilized that money to expand some of the services already in place and to add a few additional pieces, and we began to integrate everything together. Also around that time, several organizations began to release reports describing best practices for pain management, including the Department of Health and Human Services and the American Medical Association. Those reports recognize the need to take a biopsychosocial approach, meaning that you must look at all the factors that impact pain, while working in an individualized, multimodal, multidisciplinary fashion with an expanded toolbox, which is what we were already building. So as I mentioned, our focus on evidence-based non-drug approaches to pain. Patients with chronic pain who are interested in the program are generally referred by their primary care provider. And the first person they speak with is Denise, our care coordinator, who provides them an overview of the program and more details about the different services. Now you can see the different elements of on the screen, which includes behavioral health, substance use treatment, our medical legal partnership, nutrition, acupuncture, yoga, and group medical visits. All of our offerings are in English and Spanish, and we strive to hire diverse practitioners and staff that reflect our patients and community to better support them. Patients then pick what they would like to try. We like to say it's choose your own adventure. There's some real advantages to that as opposed to dictating what treatments patients should get. As I mentioned, many patients have experienced complex trauma, often related to early attachment relationships, which impacts their experiences with pain and medical care. Additionally, most of our patients are BIPOC, Black, Indigenous, or people of color, and have had very negative experiences in the healthcare system, especially around pain, so may have a legitimate distrust. We hope that by promoting and encouraging self-determination around their health, it can help the process of rebuilding trust. This is one example of how we center relational health, and we'll be talking more about this, so I'll hold off on digging into it deeper. I'm going to pass the mic to our other team members, but I wanted to mention a recent acknowledgement our program has received. Just last year, the IPMP was recognized by the Duke Margolis Center for Health Policy as an exemplary integrated pain management program. We were only one of 4 organizations nationwide and the only FQHC and non-academic institution highlighted. Now, if you want to learn more, you can read the case study and we'll provide the link for that. And I'm going to pass it over to Denise now.
Hi, good afternoon. My name is Denise, and I am the IPMP care coordinator here at Peoples. My job is to enroll patients to IPMP and coordinate all the referrals for each of the services offered. I also manage the yoga schedule. I schedule patients, follow up with them, maintain data reports, and I work with the contractors as well and communicate with them, as I am the point of contact for anything related to patient appointments and scheduling. So all the referrals I receive are in my task box, and I usually work in the order I receive them. Once I accept a referral, I immediately reach out to the patient via phone call, as I am also the point of contact for patients with anything IPMP related. Since I am the first person to contact our patients and to give them a more in-depth description of the program and the services we offer, it is important that I establish a relationship right off the bat with them that entails trust and empathy. And I do this because we get referrals of all different kinds of patients dealing with all sorts of pain. I then explain our program to the patients and let them know who referred them and why. Patients almost always know a bit about the referral since their providers let them know that someone from IPMP will reach out. I then explain all the services we offer, and patients usually like to start with one service before they try another one. So once patient chooses a service, let's say acupuncture, I immediately schedule them. There are then some questionnaires that patients have to complete, which I send to them via text in order to complete the enrollment. The call ends with me answering patient questions or addressing any concerns, and then with me providing all my contact information. I always tell patients to reach out to me if they feel like maybe the service just was not a good fit. That way we can explore other options to try, because although, for example, yoga and acupuncture are very popular services here at Peoples, there are a few patients who try it once or 3 times and either they don't like it or they just feel like it's not for them, which is totally normal. On to patient satisfaction. Having our yoga classes, therapy sessions, group medical visits, and nutrition classes being done virtually is very convenient for patients, as they are able to take advantage of these services from the comfort of their home. Especially with COVID, this is an excellent form for patients who still do not feel comfortable to be in a group setting. And while many patients do enjoy the services, there are some days where attendance is not very high due to many factors like lack of childcare. Some patients struggle to find someone to care for their children while they go to their visits or participate in virtual sessions. Also, because of COVID, there was no massage for 3 years, which was very unfortunate. Another barrier is transportation for our in-person services, since some patients live far and don't have a way to get to their appointments, or they depend on family members to take them, and sometimes it's just not possible. There have also been a few patients who struggle with the virtual sessions. Some patients only know how to answer calls, for example, on their mobile devices, or aren't too tech savvy, which makes it a bit complicated for them to connect on Zoom. And when this happens, I make sure to assist patients and walk through the Zoom functions over the phone until they are able to connect. Also, patients really love the communication, accessibility, and reliability that comes from me as their go-to person for all IPMP information or questions, because I always try to answer my phone, and if I can't, I make sure to always return their call as soon as I can. There are also our patients who hardly ever miss any of their visits because they find acupuncture extremely helpful. They find community in their virtual yoga groups and group medical visits, or they find it beneficial to their overall health to have someone to talk to in their therapy sessions. Patients also do love the ability to choose from our list of services, and the fact that we are expanding that list and adding more availability to make it for more room for IPMP referrals is pretty amazing. So let me go ahead and pass it on to Courtney.
Thank you, Denise. So hi, everyone. My name is Courtney Bailey, and I'm the trauma-informed yoga and movement facilitator on this team. I received my training through Sundara Yoga Therapy. So I want to talk briefly about medical mistrust and how integrative practices such as trauma-informed yoga and movement can help alleviate certain mistrust. So what is medical mistrust? Medical mistrust is defined as the suspicion of healthcare providers, organizations, and/or systems. It's become a major public health problem as it negatively impacts health-related behaviors. Some of these behaviors include the good old adherence to medication, cancer screenings, organ donations, clinical trials, and utilization of healthcare services. This term, medical mistrust, was derived from the Cultural Mistrust Inventory, which was coined in 1981. This cultural mistrust was created to address Black folks' mistrust in white people and I guess the dominant culture in the United States. Medical mistrust can be fueled by historical events and generational trauma. For example, the father of gynecology, James Marion Sims, experimented on enslaved Black women without any form of anesthesia. And that's an image right there of the father of gynecology. I don't know this for certain, but I would say that this has even added to this medical belief that Black people experience less pain than white people and other people of color. Although anybody can experience medical mistrust, people of color are most impacted by this issue, and they may miss out on advances in healthcare and routine visits. Providers perpetuate medical mistrust by biases, stereotypes, microaggressions, and racist behaviors in our policies. And for example, one example of maybe a microaggression is not believing when a patient tells a doctor what they're experiencing, right? As if they don't know their body. That can be seen as a microaggression. At People's Community Clinic, we aim to improve relationships with patients by actively seeking ways to build trust by inviting patients to be active decision makers in their own healthcare. So now I'm going to talk a little bit about trauma-informed yoga and how that's a part of this. So I've been teaching trauma-informed yoga for about, I don't know, like 6 years. And trauma-informed yoga, it doesn't focus on the physical aspect of yoga. It more so focuses on the participants' ability to self-regulate and use more mind-body techniques. And at People's Community Clinic, I use chair yoga instead of the traditional standing poses that we know. Chair yoga alleviates most issues of physical limitations. Participants can practice the techniques almost anywhere, at work or at home. And most importantly, people learn how to self-regulate through checking in, breath work, repetition of movement, and establishing a sense of community and togetherness. And all of this builds trust because I don't do anything without considering the participant and their self-identified needs. And I'm happy to answer more questions about this when we go into our Q&A. But in the meantime, I'm going to pass it to Jess.
Awesome. Thanks, Courtney. So I'm Jessica, and I'm the Substance Use Clinical Program Manager here at People's. So I work on a couple of different levels at the clinic to kind of help the clinic as a whole expand our ability to reduce stigma and integrate substance use treatment into our primary care setting. And I'm happy to answer any questions you'll have at the end, specifically about kind of the pieces of the substance use treatment components. But I'm really excited to talk to y'all right now about kind of this theme of relational health that really drives the philosophy of how and why we build built the IPMP program, and also I think what really excites us about kind of the work we do on a day-to-day basis. So one of the things we really like to keep in mind, and that Sheridan, Courtney, and Denise have already spoken really well to, is the fact that most of both chronic pain and, struggles with substance use are often things that may be the most visible in healthcare settings, whether that's from like a provider standpoint or even from the individual, right, in terms of what's causing the most distress in your day-to-day. But those things really sit on top of layers of other harms often that have come before. So whether that's individual, institutional, or structural racism, intergenerational and or interpersonal trauma, the people in our program have been harmed in relationships and they've been harmed by systems, right? And that includes the medical systems. So we have a lot of different layers that we try to take into consideration when we conceptualize, what healing and support might look like. Because again, for a lot of our folks, the people and the systems that were supposed to keep them safe have historically been the sources of harm, right? So what that can look like interpersonally is that, a lot of folks have a hard time trusting, for good reason, that other people in the medical system, that, other people are going to listen to them, are going to believe them, are going to have their best interests in mind, let alone are actually going to be able to help them, right? So we're talking about kind of overlapping chronic and complex experiences and conditions that live not only in people's bodies and in their nervous systems, but also in kind of like their relational expectations, right? And the strategies that they developed for survival and protection based on those things. So all of that is alive, in all of us, right? In anytime we're in an interpersonal reaction, but it's also alive in a 15-minute provider visit, right? So there's no quick solutions for that. And as I think we're kind of preaching to the choir here that y'all know that our medical system doesn't really set us up well, right, to handle that. It doesn't set us up well for people to feel seen and heard. And it doesn't set us up well for what like longer term healing and recovery might look like, right? If you've got 15 minutes, you need to be able to name something quickly, you need a quick fix, you need intervention, you got to get people out the door, right? Even like the most caring professionals have that pressure, right? So you can really see how medication can become one of the most utilized tools in the toolbox. So our whole program's goal is to move kind of from that, like, what's wrong with you? What do we need to fix mentality into understanding both like kind of what happened to you and also what matters to you, right? To create kind of different pathways for healing. So again, that looks like a lot of different things, but some of that looks like the choose your own adventure that folks have already spoken to, and also this just like really relational frame. So kind of Denise already explained what a crucial role she plays in terms of making sure that like from the get-go, the first point of contact is really relational, right? So Denise reaches out to folks, she establishes that relationship that's based in empathy. She explains the different pieces of the program, but she also listens to patients, right? For them to tell her which of the services we have sounds the most interesting or the most comfortable, and then they can ask her questions, and then they can kind of check back in with her, let her know how it goes, make adjustments, right? So there's all these different relational touch points. We also think it's really important to have different pathways for kind of receiving care, right? So obviously as a social worker, I'm a big fan of therapy, but we also think it's really important that that's not the only avenue people have for getting help, right? And that patients don't only have to go through that kind of power dynamic that happens in a one-on-one relational frame, right? So we also think it's really important to have like yoga and acupuncture and massage, right? Places where people can have the things they're struggling with be real, but kind of receive tending to it in different ways that doesn't always involve having to share their stories, right? And Sharon is also going to talk more about our integrated group medical visits, but this is another place where our relational health really stands out. A few highlights: the structure of the group itself is designed to be non-hierarchical. So, the other healthcare providers who participate, the medical doctors, the social workers, they share pieces of themselves as well to kind of dismantle that hierarchy of just having like the professionals on one side and the patients having to be the only ones being vulnerable. And then patients also get to learn from each other. So again, I'll let Sharon talk more to that. But the thing I guess I really want to highlight is, we're not just giving folks different options for receiving care, whether that's learning about inflammation and chronic pain or going to our other services, but we're also giving people a different experience of being seen, right? Of sharing what's happening with them, of having other people believe and relate relate to and share their own struggles and successes. People are going to need to take in not just interventions, things about them that need fixing, but they also get to have different relational experiences where like their pain, their experiences, and their joy matter, right? And where they themselves matter to other people. And I'll say that one of the most common things we hear from folks, I can't tell you, how many times I've heard this, is, folks will, because we do sort of an assessment around patients' depression and suicidality. And a lot of times folks will say, I was having a really hard day with my pain. I was thinking maybe I needed to see my doctor again. Maybe even some patients are thinking about going to the ER, or maybe even having, feeling suicidal, right? And they say, and then I went to group and I realized that I wasn't alone and I felt better. And I know that sounds wild, but like people just say that over and over to us. So we really think that this experience of kind of relational connectivity is an important part of what IPMP provides. So that's, I'm going to take a little breath. That's my piece, just talking about relational health. But since our colleague Kelly Roberts, who's the IPMP program manager, can't be here today, she shared with me kind of what she was hoping to talk to y'all about. So I'm going to do my best to capture all the valuable things that she brings to the program as well. So one of the things that Kelly's role is really crucial in doing is making our integrative team possible, right? So bringing together all of these different folks and all of these different contractors, right? Because some folks are already part of the organization, but a lot of folks bringing in acupuncture full-time, bringing in yoga, working with Courtney and Sundara, and bringing in massage, and even facilitating all of the credentialing and onboarding. There's a lot of like logistics that go into making that possible and working that into a federally qualified health system, right? And even before we get into like those logistics, we have to find the people, right? So Kelly's done just an amazing job with community outreach and connecting with folks who share kind of like a similar health philosophy. And so that really involves community resource mapping and making personal connections with outside practitioners. And we feel really lucky to have found as many like-minded folks in our community who, have a desire to work in an integrative medical setting alongside allopathic practitioners. And Kelly really says, which I love this, that she really suspects that a program like ours, might look very different if it was located in a different community, right? Because it would be reflective of the people that are in that community. And that actually is kind of the beauty of working with the program in the way we do, is that it makes for a really organic, community-oriented program. Kelly also wanted to make sure we highlighted some of the, logistical challenges that come with this, right? So there's the components of creating protocols and systems for practitioners who traditionally haven't been part of medical systems, right? So again, the credentialing, the contracting, all of those pieces, and then also just carving out a space for them, right? And there's a lot of work Kelly, and Denise do as like liaisons between the allopathic practitioners and the administrative staff who are more used to working exclusively with like traditional medical practitioners, right? So it kind of requires some translation in both directions, right? You have to kind of educate and support the more integrated practitioners in adjusting to the rules and protocols and procedures of our medical clinic. And then we also have to do a lot of like liaison work in terms of getting our medical providers. Obviously, Sherrod is already on board, but some of our providers are not as familiar with some of these services. And so we have to kind of help them see how they can integrate it into their patient's treatment plan. So Kelly does a great job of pushing the idea that like they can think of these things, kind of try to speak their language. They can think of these things as things you can prescribe your patient yoga, right? Imagine like instead of just having medication as the thing, you could prescribe group, you could prescribe yoga, things like that. And we also really, our patients tend to have a fair amount of trust in our providers. And so we also like to remind them that like a recommendation from them can go a long way towards encouraging a patient to try something new. The last thing I want to touch on that is like another way where we kind of bring other medical providers that aren't part of IPMP into the fold, but also where I think our relational health really shines is our bi-monthly case staffings, our collaborative case staffings. So this provides a really crucial venue for true integrative care, right? And I think Sharon's bringing up an image of a real life case staffing back when we pre-pandemic. But so this is the place where we can all come together and, share our different experiences with patients, right? Maybe I've seen someone in therapy and I'm wanting to refer them to acupuncture. Well, the more we can talk to each other and share what we know and also learn from each other's perspectives, the better we can understand and support our patients. So really important to highlight that the goal is not about like, again, finding the magic solution, but it's about creating a space where we can learn from each other's diverse perspectives, but also feel supported, right? just like it's powerful for our patients to not feel alone, it's really important that we don't feel alone in the work we're doing, right? And I think too often, even an integrative healthcare center like People's, folks can get really stuck in their silos, and they can kind of feel like, especially I think caring, helping people can kind of take on all the responsibility and feel like they're the only ones responsible for responding to the complex needs that our patients have. So it's really important that we have this opportunity where we can learn from each other and also feel supported, right? So it's a place where we get to share different wisdoms of perspectives. You know, we have acupuncturists, our, you know, yoga instructor, soon to be massage, primary care doctors, nutritionists, social workers, legal, all of those people in the room, right? And we get to benefit from those different perspectives, but we also get to have a space where we like hold space for each other, right? To process what's going on with us in these complex situations, you know, and have a space to share that. So it's a place where we can feel, you know, part of a team. And I think as helpers, you know, our nervous systems are one of the greatest offerings that we have, right? It is a tool for healing, right? Where we are in our bodies and our nervous systems informs how present we're able to be, and folks can feel that, right? So the more kind of resourced we are, you know, the better. And I just like to highlight, and I think, again, hopefully I'm preaching to the choir, but like relational health is not just for patients, right? Like staff's nervous systems matter too, right? And I think so often certainly in traditional medical settings, even the most well-intentioned ones, we kind of forget to create ways to honor like the humanity of our bodies and our nervous systems, right? Like, because there is so much need that we're responding to. And so we think this is a really crucial component of our case steppings is a really crucial component of where we kind of bring that back and really mitigate burnout and that sort of like isolation. And again, that's where we also kind of bring other providers who aren't part of IPMP into the folds where, you know, I can't, you know, sometimes you reach out to them and we're like, hey, you know, you're struggling with this patient. Do you want to bring them to a staffing? And sometimes the first response is like, oh, no, I don't have enough time. And we have to really help them see like, no, we're not asking you to do anything else, right? Like we want you to come so that, you know, you're not alone, so that you can get more support. So that's my best attempt to talk to some of the pieces of the program. And I'm going to hand it over to Billy now to talk a little bit more about the acupuncture component.
I think I have 2 or 3 things to talk about, one of which would be kind of addressed to the biomedical practitioners who are listening and to the people who are in admin and decision making. And the other would be to the acupuncturists or complementary health, alternative health practitioners. And also the last thing is just my personal experience of what it's been like at People's. I started out, so I'm Billy Zachary. I'm the acupuncturist on the team. I've been working in the role of supervising acupuncture students at the student clinic here at People's since I think about 2016. And when the Integrative Pain Management team started, they came and recruited me. They came and invited me in, and that was really important. That outreach that Dr. Coley did and Kelly did, and there was a project manager, Mulaney, who was helping to start up the project to bring us in, right? Like Jessica mentioned, there's this tendency for us medical practitioners to get siloed off into our little bubble, our little silo where we're not connecting with other people. And I think I would say 5-6 years ago, I'd sort of just accepted that's probably going to be the trajectory of my acupuncture career. So I'd always hoped for integration like this, like we see here at People's, but knowing whether or not, knowing how far away it was, I always imagined it was far, far off in the distance. So that kind of outreach from the practitioners has been really important to bring me in. So if you have if you want to bring in acupuncture, so you want to bring in yoga, you may want to also do some of that reach out. I think that was really important for bringing me in. Let's see, what else do I want to mention to you guys? As an acupuncturist at the program, sometimes I find it's important to still be able to reach out and talk to all the doctors, not just here, not just in our bubble of the Integrative Management Program practitioners, but to doctors as a whole, right? So maintaining really good lines of communication with everyone at the clinic that you can is really essential, really important, you know, all the kinds of medical directors who are here. Jessica mentioned the kind of flat hierarchy we have in those case conferences. To me, that felt really essential for bonding us as a team and getting us working together during that first few years. I really like to praise Dr. Coley and Kelly and everyone in the leadership at People's there for keeping it a very flat organization, a very flat hierarchy. There always seems to be everyone's voice gets included. And even if someone's a little shy that day or not speaking up, you know, that gets tracked and it's made sure that people's voices are brought forward. And no one's treated as necessarily a higher authority just because they have a particular role or rank, but we really respect the knowledge that each person's bringing in. Jessica also mentioned that benefit to us as practitioners, right? When I'm working with a patient who has a very difficult case, you know, off in my own private practice, and if I'm working with someone who's under-resourced from a socioeconomic position, there might not be much I can do. But here at People's, we have our medical legal team that might be able to bring extra resources in that wouldn't normally be available. So things that are normally really out of reach for me with a patient might be in reach. I have a nutritionist I can refer to really have a patient get some quantity and quality time getting coaching. And of course, there's the biomedical team, right? The conventional medicine that I can refer people to. Acupuncturists. Okay, I'm going to run out of time here shortly, but acupuncturists, things I want to say to you. Of course, we know we have to code switch when we're talking to our biomedical partners, but they're not a monolithic group, right? Nurses talk differently than the IBH folks. IBH folks communicate differently than the medical doctors, and everyone's individual. So you'll be doing a lot of code switching. Be fluid with that. Be fluid with the style of treatment that you give. Be willing to change the format, go from community to individual, longer, shorter treatments. I'll be available in the Q&A if you guys have any other questions. And I'm going to pass it on to our next speaker, which is that AJ?
I think it would be Jen, but since she's not here, I'm going to cover her part. So,
okay.
Yeah, let me move to the slide forward here. All right. So I'm going to talk about, oops, where'd it go? Where is it? There it is. Groups. So Jen Beltran, our group visit coordinator, couldn't be here. So I'm going to try to discuss the importance of group visits within our program. So we want to be able to provide culturally responsive care. So groups are actually the centerpiece that pulls everything together. So for those not familiar, group medical visits are an innovative value-based model where patients receive their medical care in a group. A provider has a face-to-face visit, so it's billable. But there typically is more time for education, information about self-management, peer-to-peer learning, and connection. Groups are increasingly being used in underserved settings where so many patients are lonely and isolated. When patients are able to come together and realize there are others who are going through something similar, they often feel less alone and more supported. Patients end up willing to try things that they might not otherwise, to make friends in the group, and they hold each other accountable. Now, the groups that we have are patient-driven. The group members help determine the specific topics, and they focus on education, support, and community building. There's much more time for patients to be truly heard, and the patient practitioner hierarchy gets flattened as the clinical staff become participants of the group. Now, on the right, you can see a picture of a group member leading a discussion at the whiteboard. And I can't overstate the importance of the peer-to-peer educational component. Patients are more likely to believe and trust someone who has lived with a chronic condition for years and has learned what helps and what doesn't. Now, as was mentioned earlier, our focus in the program is to support relational health, with the understanding that unresolved complex trauma and the difficulties that come with it around self-regulation and attachment is often the driving force for many of our patients' symptoms. We designed a program that focuses on laying a groundwork for personal and interpersonal repair. We're not just taking into account their physical symptoms, but also their isolation, hopelessness, difficulty managing distress, and getting their needs met in relationships with others like family, friends, or even their healthcare team. The self-directed structure of the program itself, and especially the group visits, create multiple opportunities to try new things that may help them heal, whether those things are new foods, movement, acupuncture, or simply practicing receiving care from another person, which is not a given with folks with complex trauma. We hope to build community, but also rebuild trust for patients in a healthcare system that may not have always treated them fairly. And groups go a long way to helping with that. So we've completed 11 cohorts of our pain groups. Due to staffing issues, we typically have been alternating English and Spanish groups, but in the new year, we should have both English and Spanish ongoing simultaneously. We've also held groups specific to anxiety and a Spanish substance use group. The pain groups are typically once a week for 8 weeks. The first 2 weeks are a basic overview about chronic pain, inflammation, and the pain and stress response to set the table. But in the remaining 6 weeks, patients get to choose from a menu of topics, which include nutrition, mental health care, healthy sleep, herbs and supplements, music and art, social support, racism in healthcare, patients' legal rights, and more. In addition to talking about a particular topic, we may do yoga, play games, do art, listen to music, cook when we're in person, or do other things that can promote healing. The pain groups are typically facilitated by a physician who writes notes and bills, a social worker, and a nutritionist, and this varies a bit with the other groups. We may have guests drop by depending on the topic, so that could be the medical legal attorney, it could be an acupuncturist, it could be others. Many of the participants who attend one group end up joining future groups. The ongoing support keeps them coming back. Now, as you can see in these pictures, our groups were initially in person, but with the pandemic, we've had to shift, and now all the groups are on Zoom. While we may lose a bit of the sense of connection because we aren't able to gather together, cook and eat together, or move together, we found that we still can build community virtually. And in fact, it's easier for many of our patients who suffer with chronic pain to not have to make their way into the clinic for group. Instead, they can just join from the comfort of their home. And we do hope to have some in-person offerings in the near future, but more likely we'll keep some sort of a hybrid model. And the patients love groups, and kind of like what Jessica was saying earlier, you know, like I had one specific patient I remember who wasn't feeling great, and she decided to join the group anyway that day. And at the end of the session, usually I just am like, hey, does anyone need to see me for a visit? And she said that, hey, you know, I initially was planning to, but after the group, I feel so much better. I don't really need to talk to you anymore. And so that's great. That's like the goal, right? Like patients don't need to always see the practitioner, but can heal by being supported by their peers and what our friend and colleague Jeff Geller calls the group inclusion effect. And to me, that's much more powerful. Like it's the idea of community as medicine. And so that's all I'm going to say about groups. We can, if you have more questions about that, we can talk in the Q&A. I'm going to pass it over to AJ, who's going to talk a little bit more about evaluation and just sort of data.
Thanks. So my name is AJ Jaraska. My pronouns are she, they, and I'm the director of analytics and evaluation. And I'm going to talk a little bit about what we're learning about the program. So it's still a pretty new program, especially given that it hadn't been up and running for very long before COVID. And so we're really just now getting some practices in place around gathering data on a regular cadence. So we are going to be and have started gathering data at baseline, 6 months, 1 year, and annually thereafter. We do collect all of the data that you see on the screen with a couple of exceptions and caveats. One is pain is very hard to measure, as I'm sure many in the webinar understand. So we don't put a lot of stock into the pain rating scale, though we do collect it. Additionally, the physical health measures are collected when it's medically appropriate to do so. So we don't collect that on the same cadence. So for example, if a patient is diabetic, they would have their A1C drawn at whenever that's appropriate in seeing their provider. Most of our patients are not on opioids, as Dr. Coley mentioned, and we have had trouble getting ER data and having the bandwidth to really analyze that data. So that's something that's been a struggle, though we do hear anecdotally from patients that this program has influenced their decisions around going to the ER for some of their needs. The measure that we really are the most interested in at this point is related to quality of life. As I believe Jessica mentioned, we're less interested in what's the matter with you and much more interested in what matters to you. And for most people, even though their pain isn't necessarily going to go completely away, we do hope that their quality of life can improve. So we've opted to use the Harvard University's flourishing measure, and you can see some of those questions on the right-hand side of your screen, because that's actually the ultimate goal of what we're hoping changes with this program. Because we have had challenges for a variety of reasons collecting quantitative data, and also because for anybody who has an evaluation background, I knew my dog was going to start barking as soon as I started talking, but hold on one second. I'm going to turn off my camera and move so you can't hear him. But as anybody who knows evaluation and research, the gold standard would be to do some kind of randomized control trial, which isn't realistic in this kind of environment. And we also know that anytime there's a choose your own adventure, that's awesome for the patients, but very hard from a data collection standpoint. So, so we're really interested in the qualitative data in particular. And you can go ahead and move to the next slide, Sherrod. We had the great fortune to have a third-year medical student who was able to do some qualitative analysis after interviewing 9 of our patients, and 4 themes emerged from those interviews. So unsurprising to us, pain is a persistent and challenging reality. Also unsurprising, especially for our patients of color, as Courtney spoke to, the burden of previous negative encounters with the medical system fosters distrust and hopelessness. And so the thing that was really helpful about this for us is while many of us know that our clinic is not immune to these challenges, sometimes those of us coming from a helping background think, well, I'm well-intentioned and therefore it doesn't happen here. But it's really helpful when we get direct information from patients that go to the contrary of that. So it did come out in this qualitative study that it wasn't just the pain specialists and ER emergency rooms where patients were experiencing negative encounters, especially related to race. It was also from their primary care providers at our own clinic. And so this is something that we continue to work on as a clinic. And it's an ongoing issue that we are working to address. But it also reemphasizes the importance of this program and understanding all of these issues at play, and thinking about how we can build those relationships like what Jessica talked about. So the third and fourth key themes were really validating for us, because patients said that connection and integration diminishes their distress, and patients, when they have coping skills, they do take steps to reduce pain interference. And so we do feel like, even though we don't have a lot of quantitative data yet, we are hearing qualitatively, and I always say qualitative is still a rigorous methodology, that this program is achieving the things that we want to achieve, even though we have a long way to go. I did want to just very quickly mention that we are also in the process of working with our local healthcare district. As Sherrod mentioned, we're in a state that hasn't expanded Medicaid, so our local healthcare district provides some supplemental funding to help cover our patients who are otherwise unfunded. And so they've been very interested in this program, and we've been working with them to provide information, hopefully ultimately to get to a per member per month rate, which we think will be make much more sense for a program like this, where there's so many different components involved and we have a lot more intensive services. But at the moment, the first year they want to do is a fee for service. And so we're in the process of negotiating those rates right now. And then hopefully we can use those fee for service the data from the fee-for-service process to then set a per member per month rate. So that's very exciting. We've looked at a lot of data to figure out what we think we can do in the coming year in terms of service offerings, which is also challenging, both because of COVID and because the program is growing, and then also trying to understand what our costs are and what we need to ask for in order to make it worth it. So that's everything that I was planning to cover, and I'm the last speaker. So I just want to say thank you so much to everyone for listening to us. And I do believe we have a little bit of time to take some questions. Please also check the Q&A. If you haven't already, we've answered a number of questions there, but you can put more into the Q&A as well. I can talk a little bit about the question that just came into the chat. And I know Sherrod briefly mentioned this, but we are a federally qualified health center. And so we had the opportunity to apply for a grant through HRSA. And so we got a federal grant, and some of that federal money went to this program. And so it's largely grant funded at this point in time, but we are looking to expand that. And I don't know if anybody wants to add to that.
Was the question specifically about funding, how we funded it?
Yeah, how do you fund this in the beginning?
Right, yeah, and I think that it was the opioid money that was coming in. There was actually quite a bit that was that the feds were just saying, hey, like, do something about opioids. And so a lot of people were starting like MAT programs, like medication assisted therapy programs. And our thought was like, well, why don't we create something that would prevent people from ending up on opioids? And since we had a lot of the pieces in place, we kind of took those pieces and then we used some of that funding to add in the care coordinator, like Denise's position, expand acupuncture, add in yoga, massage. So we were able to kind of, but they're limited in hours. So you know, initially Billy started, I think, with like 4 hours, and maybe Courtney had like the yoga had like 4 hours. And so, but I think with creative budgeting, like, and you know, massage didn't start because of COVID. We were able to expand some of those services, but we've kind of hit this wall where we can't really expand more. And that's why AJ, as she was describing the negotiations with Central Health, that's really important to think about ways of expanding the program beyond what we already have.
And I also just want to give a quick shout out, if we're talking about key components of the program, you know, there's services that ideally we'd like to get reimbursed for. And then there's like the crucial things that hold the program together that are a little harder to get reimbursed for, which is why we're looking at the per member per month. And that's Denise's role for the care coordination, and then our group medical visit coordinator. That the things that we're doing here would not be possible without those roles, like not only the relational holding that they do for patients, but all of the things they do to make the groups and the services happen. So I think it's really, we'd love to highlight the services that we're providing, but I want to make sure to give Denise a shout out, and also make sure that anyone out there is imagining how they might do this, like, you need those roles are completely critical, and we couldn't do it without them. So
we have an interesting question in here. It says, how was your clinic affected by the entire COVID-19 experience on care and service delivery, from Paul? I can answer that, but I can't. So someone else.
I think the answer for that could fill volumes. I'm in the middle of typing a response now, but it slowed things down for some time, and took a lot of shuffling and a lot of work to get momentum going again. One of the things that I know that we did that helped a lot was that we kept meeting. Right, we kept coming together and doing we're virtual at the time, but we were doing our case conferences, and I know at that time that meant a lot to me, right? Having this team that I was still meeting, right? It was also my support group for me for that phase. So when we did bring acupuncture back, we had to have lots of space between patients. So, right, that means we were seeing very few patients. It was very slow. We really had to, you know, adjust again, and I believe every clinic went through this, right? We had to just adjust again and again every time new information came out, when vaccinations came out, when we learned exactly how transmission's happening. Every time we would sort of rewrite the rule book on, okay, here's how we're going to be in clinic now. Here's how we're going to deliver these services. I told one of my acupuncture students, it's a bit like trying to shoot a bow and arrow at a moving target while you're riding on a dolphin on a wave in a storm, right? There was just dealing with many changes all at once and always being ready for like the rules that we establish to need to be rewritten the next day.
And I'll add that, like, and as I kind of mentioned it earlier, like, we did have to change quite a bit, like all the in-person things, like our groups had to go virtual. I think yoga, we started virtual. We may have had some in-person for that as well, but when eventually shifted virtual. But I think, as I mentioned, like, I think it was actually in some ways better for some patients to be able to just like not have to like take a bus or get a ride down or drive down to the clinic, and actually be able to just like log on. Like a lot of people told us with the groups, like, yeah, it's pretty low risk for me. Like, I just basically can decide to log on Wednesday afternoon if I want to and join a group. And if I don't want to, I don't have to, but it's like, they don't have to like, make their way down. And so that's been the silver lining, is that we've actually learned different ways and to be able to kind of create this community virtually. And I think it's benefited a lot of patients who might not otherwise have been able to participate.
We've got an acupuncture question.
So
Jen.
the format I'm treating in right now, I don't quite have the room set up, so it's hard to show you, but I have patients in sequence and overlapping, so that while one patient's resting with needles, I'm intaking and getting the next started. We've looked at doing some NADA groups. I certainly have a lot of experience with that, but we haven't put it into practice yet here at Peoples. We're starting to do it just before COVID hit. That's disrupted that. So right now I'm still at this moment doing a kind of community setting, but still seeing people one-on-one. I mean, one of the other things is I check blood pressure, I do vitals as well. I'm charting into the system. So that would be much more challenging, and all the patients in an environment where all the patients are showing up at once.
I think we've got another question here, maybe a final one. Within the group setting, how many patients do you end up completing a billable medical visit?
So I can answer that. So since Jen's not here, but in our groups, typically it's a little tricky because they're weekly groups. So I don't actually bill every week for each patient. We do 8 weeks, and I will bill the first, the midpoint, and the end session, so the 3 within it. And then we typically have I think we have about 8 patients in the last few groups that we've had. So I bill on those particular sessions. And then in the in-between sessions, I just sort of offer people visits if they want them. They don't have to see me, but like the first, midpoint, and end, we're just kind of doing check-ins. In between, if someone's like, hey, I had this issue come up, can I talk to you? I'm there and available. And so in the current system we have, those are the only billable visits that we can do. But ideally, as we move into this sort of more value-based model with Central Health, we're hoping that they're actually going to be reimbursing us just for patients participating in groups, because they realize the value of that there's just something about being engaged in care that can kind of keep people healthy as well. So we are like I think the model is shifting a little bit. And there's some other models I know, like in centering pregnancy in South Carolina, Medicaid is now paying clinics just for having people engaged in the groups, as opposed to the actual like doctor visit that happens in it. So.
Wonderful. Well, we're nearing the end of our hour. So I want to say thank you to all of you, Courtney, Billy, Jessica, Sharon, Denise, AJ. That was a wonderful presentation. It looks and sounds like you work as a team amazingly well. And from what I can tell, there's so much care and individual attention and thought that goes into the work you do. That really came out in this presentation and discussion. So I want to thank you on behalf of the IPW team. for your time and efforts to bring this to us all. And Tabitha, did you have anything you wanted to say to round things up?
Yeah, just also want to thank your entire team. What an amazing model, and just you're all really fantastic information and inspiring to all of us. There's so many great comments in the chat and online about the work that you all are doing. And so I just really appreciate the service you're providing to people that really need it, need care, and need kind of a holistic model that's bringing that to them in the way that they can access it and that empowers them. So really fantastic. And thank you all for being here. For those of you who are interested in the Academy, feel free to connect with us. You can do that on all of our different channels. We're AIHM Global. And if you want to go back and rewatch this or share it with friends, it'll be on our YouTube channel. You can find it on Facebook on the Academy site. And definitely share the resources. There's so many great things presented today. So thanks again for being here, and we hope that you join us. Our next session will be establishing an interprofessional model in an integrative health sciences university, and that will be on December 9th. Dr. Pradeep Singh will be joining us from SCU in Whittier, California. And also, so for those of you health clinicians out there, we have put together an incredible Heal the Healer retreat that is happening this January 6th to the 8th at Rancho Bernardo Inn in San Diego. Doctors Bradley Jacobs and Rachel Abrams, two phenomenal people and clinicians, are going to be putting on a really incredible retreat for the burned out health professional. And so if you're interested in that, check it out. It's going to be a really, really great experience. And finally, again, the early bird special, if you're interested in the fellowship, if you're interested in really getting trained at a fellowship level in integrative health and medicine, and you are an MD or nurse or acupuncturist or ND, anyone that is practicing clinically and has a master's degree. We also just opened up the program to RNs. So if you're interested in that program, it's 2 years. Our next cohort starts in April, and you can get a early bird special that takes $2,000 off tuition and $100 off the application until December 31st. So come check that out. And yeah, join our global community. We are really building a global community of all of us that are working integratively as teams. And we hope that you come and be a part of that as we work together. Thanks again. And thank you to the People's Community Clinic from Austin, Texas, and your amazing team and all you do to serve the community. See y'all soon.
Thank you so much.